For centuries, society has viewed severe mental illness through a single, blunt lens. The complex architecture of the human mind was historically reduced to a monolith of madness or insanity, an entity that broke and fractured into pieces. Modern diagnostics, like the DSM-5, abandon that monolith. Psychiatry now classifies schizophrenia as a defined spectrum of psychotic brain disorders. The defining baseline of this spectrum is psychosis. Psychosis is a clinical syndrome that disrupts a patient's thinking, perception, emotion, and cognitive functions, resulting in a severe, measurable disconnect from reality. This cognitive disconnect is exactly where the terminology misleads the public. The word schizophrenia translates literally to a splitting of the mind. This refers to a fracture in cognitive functions and a fragmentation of thought processes. A patient with schizophrenia does not harbor multiple distinct identities. The presence of alternate personalities belongs strictly to dissociative identity disorder, a separate clinical entity entirely. Despite this precise clinical distinction, legal systems often lag decades behind medical science. Physicians are forced to operate within archaic legal frameworks that rely on outdated concepts of insanity. In the Syrian civil status law, for example, there is no specific classification for schizophrenia. This system forces these complex spectrum disorders into broad, binary categories of insanity, treating it as either permanent or episodic. To accurately treat the disorder, clinicians must bypass these legal stigmas and societal myths to examine the precise biological footprint of the disease. That footprint begins at the deepest biological level. The root etiology of schizophrenia is heavily anchored in genetics, establishing the primary vulnerability or diathesis for the disorder. Across the general population, the baseline prevalence rate of schizophrenia hovers at exactly 1%. This table charts relative risk. As kinship draws closer, probability scales up. First-degree relatives face a 12% risk. If both parents are affected, it spikes to 40%. So identical twins, if one develops schizophrenia, the other has a 47% chance. This high concordance rate is driven by a polygenic architecture. The susceptibility is tied to specific regions across multiple chromosomes, including loci on chromosomes 1, 5, 6, 8, 10, 13, 15, and 22. These genetic loci operate like a manufacturing plant for neurotransmitters and neuroproteins. A defect in the chromosomal blueprint directly compromises the chemical products regulating the brain. The identical twin concordance rate peaks at 47%, stopping short of 100. This statistical gap proves that genetics alone cannot manifest the disease. Environmental triggers are strictly required. Adoption studies reinforce this dynamic. Children with high genetic risk who are adopted into stable, healthy environments retain their vulnerability to the disorder, confirming the diathesis remains active regardless of upbringing. Genetics provide the essential biological susceptibility. They load the mechanism, waiting for environmental factors to trigger the onset. When that trigger is pulled, the effects extend outward from the patient's brain, leaving a distinct macroscopic footprint on their socioeconomic life. Epidemiological data consistently logs a higher prevalence of schizophrenia within lower socioeconomic classes. This correlation is explained by the downward drift hypothesis, which clarifies the strict direction of causality between poverty and the illness. Poverty does not cause schizophrenia. The severe cognitive and functional impairments of the disorder strip patients of their ability to maintain employment and relationships, forcing a downward drift in social and economic standing. This decline is coupled with severe physical health risks. Patients with schizophrenia experience a significantly reduced life expectancy compared to the general population. The primary drivers of this mortality are comorbid physical diseases. These conditions are heavily exacerbated by a smoking rate approaching 97% and substance use rates exceeding 50%. Survival is further complicated by diagnostic overshadowing. In clinical settings, physicians often attribute genuine physical distress, such as the acute pain of a ruptured appendix, to the patient's psychosis, ignoring fatal physical symptoms. Schizophrenia actively ravages the patient's physical health and societal position alongside their cognition. The onset of this systemic disruption follows a highly specific chronological timeline, revealing distinct demographic anomalies between sexes. Onset peaks early in males, between 15 and 25. Female onset is delayed, clustering between 25 and 35. Furthermore, individuals born in winter, January to April, show higher incidence. This aligns with maternal viral infections during the second trimester, alter fetal brain development. The developmental window is so rigidly structured that cases emerging after age 45 are clinically separated into a distinct category known as late-onset schizophrenia. These demographic clusters and seasonal patterns indicate that schizophrenia is heavily driven by neurodevelopmental triggers operating on a strict chronological schedule. The intersection of this genetic bedrock and environmental timing forms the unifying theory of the disorder, the diathesis stress model. This model functions as a conceptual scale. On one side sits the inherited genetic diathesis, or susceptibility. On the other side accumulates environmental stress, ranging from fetal viral infections to active substance use and severe psychosocial trauma. The disorder remains dormant until the accumulated stress outweighs the underlying diathesis, pushing the patient across the threshold into active psychosis. These environmental pressures act strictly as releasing factors. They trigger the onset, but they cannot cause the illness without the genetic blueprint already established. Once psychosis is triggered, treatment faces a massive clinical hurdle, the problem of insight. Many patients lack the baseline awareness that they are ill, making standard treatment compliance nearly impossible. This clinical case details a patient with two distinct personalities who refused medication. The physician adapted, framing the pill as cement designed to merge the personalities. Though violating medical ethics, this deception was justified to secure compliance and prevent irreversible brain deterioration. This ethical tension exists because local legal frameworks lack the flexibility found in foreign medical systems. In systems like France, the law permits mandatory commitment and treatment in specialized facilities, bypassing the need for deception. Managing the schizophrenia spectrum requires a sophisticated marriage of data-driven biology and deeply creative clinical empathy to bridge the gap between objective medical reality and the patient's fractured world.